Tubercle going on right here for easy palpation. We have an epicondyle. It turns out this dog has a dot right where the epicondyle is, so that's great for us. Like I said, with a long plate, we might have to do a more extensive proximal dissection, but in this particular, we're trying to mimic a lateral epicondylar component fracture going on here. So I'll probably come up to about 50% if you look at that full extent of the humerus in my hand. So there's another dot right there for us. This is perfect in this dog.
Did you breathe that out for that?
I did. No. So we're going to have this proximal extent. Then once I hit the epicondyle, I'm going to curve gently to start to head down to the ulnar region. And of course, these are well frozen, so the subcutaneous tissues are always a little bit more tricky here. As I will struggle, don't laugh. There we go. So there's our skin incision. We're going to go ahead and continue our dissection down. I might do a little bit of it with this 15 blade. I just need a pickup.
The thumb is right there.
Awesome. Thank you so much. So I'm just going to do a little bit going on just with this. I thought I was going to start myself off with a nice one.
See, that's what I get for thinking when I think that.
I know, that's what I'm having here too. There we go. Okay. Try to get our dissection plane. So just like Dr. Hull said, I try not to do undermining, and of course I was trying to get cute with my blade here and got into the muscle belly a little bit. But you want to find those easy tunnel tracks that are going on right there for you, so that you're actually in between muscular planes instead of going right through them. Okay, so getting on my cranial edge.
Maybe over here.
The scissors are more like chewing gum than cutting.
Here's some other little matches if you try.
Sure, I'll give it a shot.
Maybe worse.
Lucky thing is we're almost already to the important stuff. There we go. All right, let me go ahead and put a little Velcro in here because you can start to see my radial nerve already. In a true fracture case, this would be quite swollen, bruised. You're going at a much slower pace than I am right now, but I wanted to show you, underlying this fascia, look how you're starting to get a hint of some of the anatomy here, and we have that radial nerve that's going to be right underneath there, okay? Now, it will be much deeper in the true fracture where there's a lot of fracture fragments floating around, hematoma, etc. So I'm always very cautious going through this section, going nice layer by layer, so that I'm making sure that I'm not causing any iatrogenic trauma to it. Okay, thank you very much. Right there, thank you. And then I just went ahead and repalpated my anatomy, so I have my epicondyle here, and I was just running my finger along the epicondylar crest, which is a good anatomy location for you, because then I will know that I need to come a little bit more curved right here, and that in front of this is going to be my extensor carpi radialis, and behind this I'm going to have my eventual anconius that I'll get down to as well, but I'm just going to get through this tight fascial component. There we go. There we are. And periosteal elevator, do we have like a freer elevator? Yeah, thank you so much. All right, so as you can see, this is where that epicondylar crest and kind of ridge is going right here. If I had cautery, that would be a nice starting zone to do a little cauterization. In this cadaver model, I'm just going to come at it with my blade and start to curve around. Here we go. Getting that exposure for us, being careful as I head towards the brachialis muscle, of course. So now I'm going to swap back out and do more of a tunnel dissection technique. There we are. Okay, and we're already getting down to the bone right here. So if I was having a fairly short plate, short section of where the fracture component was, all I really need to do from here is start clearing off cranially and caudally around this region. Now, if I need to get more exposure, I'm going to show you that proximal in a second. But now I'm grabbing and elevating a little bit off of the extensor carpi radialis. Okay, I'm not doing too crazy, but like I told you, if we actually get into this section well, keeping tight to that bone, will have a nice cranial lateral approach to the joint itself. So I can continue that forward and getting Gelpy retraction in there. Do we have a bigger AOL there?
Here, get one of the
Yeah.
Now, when you're closing, do you try to reattach that or tie it to anything?
Well, I can actually pull over my little plane right here and do a couple of sutures down there. It's mostly superficial fascia that you are closing after this dissection because there's not a lot of items to close to. I can take that extensor carpi radialis and I could reattach it to the anconeus with just a couple of stitches right there, and then I move on up to my superficial layers. So if I do a little bit of elevation right in this area and joint capsule is punctured and exposed, you'll actually be able to take a look at your joint surface if and when you need to do that. So that's right in here. We won't be able to get a very good look at it in this particular case, so I'm not going to dissect too much further. That is joint fluid right there.
In a live patient, would all of that you just did of cleaning off the bone with the blade, would you be doing with cautery, even like right on the bone?
Or periosteal elevator.
Okay.
Yeah. All right, so now if I needed to get more proximal exposure, I'm going to be very nice and gentle to my radial nerve section going on here. That is not radial nerve that I just lifted up. This is just a little piece of fascia that decided to stick with a friend. Okay, there we are. There we are. So if I needed to put a longer plate, one thing that I can do is I can just do a little bit more exposure here, and I can put an Army Navy in and get somebody to lift that up. My apologies, going up there. And I can still get pretty decent exposure if I have just some retraction in that section. So usually I'm able to do a little bit of proximal stretching of that brachialis muscle going on there. And if I put my finger at the top of the greater tubercle and you zoom out, I've actually gotten a pretty decent stretch of that exposure for most of our fracture repairs that we would do on this lateral component. If I need to jump the muscle, what I would do then is we're actually going to release that brachialis more cranially. I get a little bit more exposure of my skin here. And I would jump more proximally. So now I'm just doing my dissection plane around that brachialis. There we go. I'm going to use the blade because of these tissues.
The big one there, yeah.
That was a little bit of the pectoral attachment I just got on the cranial edge. Nope. There we go. So now he's retracting the brachialis a little bit on that caudal aspect, and just separating right here, I've now got a whole new section that I can stretch and get to. I probably should have made a little bit more generous of a skin incision if I was to do that. So zooming out, I'm now up 50% of the way. If I needed to go further, I'd extend that incision, I would tunnel under the deltoid so I could get up to the very proximal aspect. But for this exercise, this more distal area is our area of focus. And I'm going to go ahead and come back here for the anconeus. Elevate that off caudally. That'd be a little bit of cautery that I would do, as well as an elevator in a true clinical case. Yet again, you have some joint fluids coming out right there. And I would grab this fracture fragment with a proper bone reduction forceps. I would be able to grab that segment. Sometimes I do use little termites, but you need to be careful. Point to points, thank you so much. Point to points do concentrate all that force, and you can make one of those simple fractures comminuted very quickly. So I do prefer my serrated or clamshells, you may. And I'll grab that segment. This will allow me to turn that fracture so I can do the outside in technique. So if you get to this stage, we're going to cut this epicondylar crest area, and we can sneak in a sagittal saw to give you a lateral component to reduce. It's not going to be totally fair. First off, the blade always takes a kerf of bone away, which is not like a natural fracture, so it won't go back perfect. You will have a small, like 1 millimeter step defect when you're done with this particular fracture repair. And the other aspect of it is you don't have, they're never fractured in this smooth surface. You really can twist them in relationship to each other in a TY fracture and feel them kind of click in a little bit. Not every perfect fracture does that, but that is nice to find when you have to do that little condylar teeter-totter, kind of going rotationally to each other. Should we flip over? Should we have them do the lateral and then come back to the heel?
Yeah.
Or should you want me
Maybe
to
let's
do
do a
that?
lateral condylar fracture. you
Yeah.
think?
Or do you want me to show them this really quick?
No, let's just do this
Okay.
for right now.
So we're gonna do the lateral condylar fracture first, then we'll take a little demo session for the medial and cutting your olecranon. Or we might do the Philadelphia technique.
Yeah.
Any questions on this distal lateral approach?